Excellencies, ministers, colleagues and friends, I would like to welcome you to this final, the last plenary of the conference. So it is actually the final plenary. We're just waiting for others to settle down. Thank you very much. We're just going to begin the final plenary. So thank you so much for joining us. It's been a very inspiring and fascinating morning and afternoon, listening to speeches, some of the speeches, keynote addresses, the country stories, and the various exchanges that have taken place, including exchanges that took place over lunch and at the tea breaks. So it's really been very fascinating and a very, very interesting day. Today, what we did was to look back and discuss the potential of Astana as a catalyst for transformation. We look back from Alma-Ata to Astana, and we're looking at Astana as a catalyst for transformation. Basically, we've been looking at PHC as a vehicle to advance health and also to drive results for equity and for development. During the 6 parallel sessions, there have also been very interesting exchanges and lessons from countries and very fascinating, especially to hear from those countries that have been championing some aspects of PHC. And we had discussions around the models of care, workforce, financing, and so on. And we'll resist the temptation of trying to review some of those and highlight some of those the key points from those, because we'll come to those in the discussion. Over to you, Octavian.
Thank you, Lindiwe. As Lindiwe said, it's been indeed a long day. We're approaching the end of the very rich program today, and I'm sure that the very rich exchange of wealth of experience in this room is still keeping us energized and motivated. We all know that at the end of the day it's very difficult, and Lindiwe and I, we have a difficult mission to keep the dynamic after such a rich day. But I'm sure that our panelists, the high-level panelists that are joining for the session will keep us really focused on what is actually the culmination of the day, because this session is going to look into the trajectory of primary health care in the coming decades and elicit commitments to uphold the values of the Almaty Declaration and the Astana Declaration and accelerate progress towards SDGs.
Thank you. So without further ado, what I'll do is we will introduce the panel. We have a distinguished panel with us today. We have the Regional Director of the WHO European Region, Hans Kluge. We have the Minister of Health of the Russian Federation, Minister Murashko. We have the Deputy Minister of Health of Uzbekistan present. This is Deputy Minister Sharipov. We have the Minister of Public Health for Uruguay. This is Minister Karina Rando. We also have the advisor to the Minister of Health for Mongolia. This is, I hope I pronounce this is Erdembileg. I'm not sure if I've got that right. Thank you very much. And we also have with us a Director of Maternal, Child and Community Health from the Ministry of Health in Rwanda. That's Aline, Uwimana. And we also have youth. Do we have our Youth for Health Network colleague, and that is Sıla Gürbüz. Am I pronouncing that correctly? So thank you so much, and a very warm welcome to the distinguished panel. Thank you very much, ministers and distinguished panel for joining us.
Thank you. And in order to start the discussions and hear from panelists, I would like to invite our colleagues to display on the screen the results of the online platform Virtual Roundtable 4 poll, which asked a simple question. How do you feel about the future of primary health care in your context? As you could see from the screen, the glass is half full, but also the glass is half empty. And probably rightly so. We share the optimism, we share excitement, but also we learn the lessons. And sometimes some of these daunting lessons do not allow us to be fully optimistic. That's why I would like to invite first speaker, Dr. Hans Kluge, the WHO Regional Director for Europe, to elaborate on the recent op-ed which Hans delivered together with Madam Minister of Health of Kazakhstan, Guinea, where you are calling for a radical shift in mindsets, how to approach health systems and primary health care. Hans, what shifts are you referring to? How these shifts will actually help closing this gap among the pessimists?
Thank you, Octavian. And I'm very impressed at the end of the day to see such a full auditorium. Thank you very much, everyone, for joining, and to my panelists. Actually, if I think 1 year ago to the Region Committee in Tel Aviv in Israel, because tomorrow we will have our Region Committee, so it's about 1 year ago, we were, I would say, quite exhausted, but very hopeful. Because with most of the COVID-19 pandemic behind us, we thought that we would be very resilient, meaning resilience to bounce back stronger from a crisis. But since then, we faced again challenges. Number one, the health and care workforce crisis, which I used to call a ticking time bomb, and which is part of a larger picture with demographic aging, with increased needs and expectations of an aging, sicker population. Number two, we have quite a bit of a challenge in the field of medicines, both unprecedented shortage of essential medicines in our region, which we never would have thought, and the rising cost of innovative medicines. And number three, we see that for several ministers it becomes difficult, Octavian, to keep the same level of investment in health systems, while we're just coming out of the COVID-19 pandemic. So what do we see as the way forward? Two words: trust and transformation. And this, by the way, will be the central tenets of the ministerial meeting in Tallinn to commemorate the 15 years of the Tallinn Charter. And how do we do it? 3 points. Number one, the people. I think that's the paradigm shift, that we need the people as the agents of the transformation, to give the people more control over their health and care, be it to schedule medical appointments themselves, be it to have access to their medical files, and then, of course, to recognize that the health workers are the beating heart of the health system. We need to take care of our health workers. Before producing more and more health workers, we better retain first the few health workers we have and appreciate them, create good working conditions, and very important, to take care of their own mental health and well-being. Number one shift. Second shift, digital solutions. We have seen, progress in digital during COVID-19 that we were trying to make for 20 years. And all of a sudden, it became possible. But we have to make sure that they benefit everyone, that we don't leave behind the elderly people or the people in rural areas. What we have to avoid at all price is that in the future, the poor people will be diagnosed and treated by machines, by artificial intelligence. And only the rich people will be able to pay for a real human health workers who can express some empathy. So equity. And then the third shift is why we are here today, that the primary healthcare has to be at the heart of the health system, and the best way to transform primary healthcare is actually, I believe, it was Abil Overbo, the nurse from Norway, who told something, I wrote it down, very striking. She had one ask to the policymakers: don't forget who we are working for. The people, the patients. They know where the shoe pinches. So sometimes we make it a little bit too difficult. We have to be the good listener. I used to be a general practitioner practicing in Belgium, and my father taught me, listen to the patient. 9 out of 10, the patient is going to tell what is the obstacle and how can we solve it. We need to be good listeners to transform.
Hans, thank you so much for these inspiring suggestions for the shifts, and also that we need to learn the lessons from any crisis to build back better or rebounds, as you mentioned. Very quickly, we often say lessons learned, and the question is, have we actually learned these lessons, or these are lessons which still have to be learned? And then three things you emphasized, Hans: people, digital solutions, and primary health care at the heart, and with empathy and time to listen to the patients. Thank you very much, Hans. Over to you, please.
Thank you very much. I would like to turn now to Minister Murashko, Russian Federation. Minister, the Russian Federation has demonstrated impressive gains in health outcomes. And like elsewhere, an extensive network of primary health care providers have contributed to this work and to the gains. And we've listened in the course of the day to some of the experiences that other countries have spoken about. What we would like to discuss with you is, what do you see as the priorities in the next 5 years, particularly in strengthening primary health care and also in keeping PHC high on the policy agenda and ensuring that there's a continuation of investment in funding for the health workforce and other PHC priorities? Thank you.
Thank you very much. Please take translation equipment. I want to talk Russian. Во-первых, говоря, please, slide. Can you switch on? Huh?
Thank you. You can go ahead, Minister.
I have small presentation. Few slides. Few pictures. Okay, thank you. Когда мы говорим о системе здравоохранения и о декларациях, которые сегодня обсуждаем, они имеют начало в 1918 году. Николай Семашко – это человек, который фактически создал и зародил всю систему в 1918 году, которая позднее превратилась в ту систему мер по первичной медико-санитарной помощи, которая сегодня нашла отражение в нашей сегодняшней повестке. Понятно, что она изменилась, она трансформировалась, и то, что происходило в 20 веке, приобрело новое звучание в 21 веке. В первую очередь я бы хотел говорить о том, что вся система, она пациент-центрична и ориентирована исключительно на человека. И вся система, которая реализуется сегодня в Российской Федерации, она построена по принципу национальных проектов, которые поддержаны финансовыми ресурсами со стороны государства. Как говорится в старой поговорке, в магазин с одними знаниями не ходят, нужен еще и кошелек. Поэтому для того, чтобы трансформировать, конечно же, систему, конечно же, нужны дополнительные инвестиции, дополнительные расходы. Но первичная медико-санитарная помощь – это ключевое звено в оказании медицинской помощи. Фактически распределение сегодня в стране, в России происходит 40% это первичная медико-санитарная помощь, 40% это стационарная помощь, 20% это скорая помощь и несколько других экстренных вопросов. Когда мы говорим о непосредственно обеспечении доступности медицинской помощи, мы закладываем в то, что удаленность от места проживания должна быть минимальная. Поэтому Россия протяженная страна, но доступность первичной медико-санитарной помощи обеспечена в каждом населенном пункте. В городах это огромные большие поликлинические подразделения с мультидисциплинарными бригадами. В сельских населенных пунктах это небольшие, как мы их называем, фельдшерско-акушерские пункты или врачебные амбулатории, которые работают на этом направлении. И плюс, вот здесь на слайдах представлены те новые модели для села, для первичного здравоохранения, и плюс мобильные комплексы, которые выезжают в населенные пункты и фактически проводят осмотры и профилактически и помогают в постановке диагноза и в профилактических мероприятиях. Ну и, конечно же, в нашей стране невозможно без авиации, и поэтому санитарная авиация, вертолеты – это еще один проект, который сегодня реализуется в стране. Говоря о помощи, доступной в любом месте проживания, конечно же, первая часть, которая была реализована, это доступность интернета. Во все населенные пункты, где, соответственно, есть медицинский объект, была доведена интернет-связь. И плюс все оборудование, которое сегодня закупается, это только цифровое оборудование с возможностью передачи данных. Плюс должна быть доступна аптечный список, и в каждом сельском населенном пункте, где есть медицинский объект, обеспечена продажа лекарственных препаратов или бесплатный отпуск для льготных категорий. Формируя идеологию и парадигму первичной медико-санитарной помощи, в конечном итоге мы подходим, что жизнь человека строится по нескольким направлениям, 3 основных ключевых этапа. Первый – это период детства, когда мы формируем здоровье, когда ребенок получает комплекс профилактических мероприятий, вакцинацию, включая в том числе осмотры и сопровождение до возраста зрелости. Это период, когда мы сохраняем здоровье трудоспособного человека и когда мы поддерживаем лиц старшего возраста. Все это, конечно же, сегодня облечено в цифровой профиль пациента. И цифровой профиль пациента, он формироваться сегодня начал с момента рождения, с момента, когда только ребенок появился на свет. И профилактический континуум, который сегодня именно является ключевым, начиная от популяционной профилактики, индивидуальной профилактики, вторичной профилактики у пациентов, имеющих хронические заболевания, все это в конечном итоге погружается в единый информационный пул и позволяет врачу ориентироваться в проблемах пациента. Говоря о системе развития здравоохранения, территория России огромна, но при этом мы понимаем, что каждый субъект, каждая область имеет свои особенности, южные регионы и северные регионы. Поэтому цифровой менеджмент, он очень активно развился в период пандемии, и сегодня с каждого врачебного участка, от каждого врача мы собираем информацию о состоянии здоровья именно прикрепленного населения. И тем самым мы формируем регионы, понимаем, где какие проблемы существуют в том или ином населенном пункте. Вы видите, что вот это одна область, в ней есть как зеленые зоны, так и красные зоны. Тем самым мы понимаем, какая помощь и какие проблемы необходимо решить в том или ином населенном пункте. Следующая часть – это, конечно же, когда мы говорим о целях развития и цифровой трансформации, мы утвердили стратегию, в ней есть преемственность, эволюционное развитие, и, конечно же, здесь есть бенефиты для каждого участника, и для пациента, и для системы здравоохранения, и в целом для политического руководства, для того, чтобы понимать перспективы расходов, в которых нуждается пациент. Говоря о цифровом здравоохранении, мы пошли по пути создания цифрового домена здравоохранения, в который существует по единым принципам. Это глоссарии, это справочники, это единая система обмена данными, которая включает в том числе медицинскую продукцию, медицинские организации, и формируется цифровой профиль пациента, врача и медсестры, плюс цифровой профиль медицинской организации. По сути дела, это лицензионные требования, мы понимаем, кто, где, что может и за что может отвечать. И следующим этапом в цифровой трансформации, конечно, происходят колоссальные изменения, касаемые внедрения искусственного интеллекта и многих других вопросов. Вот вы видите, здесь на слайде представлено, например, 72 региона Российской Федерации уже внедрили программы с искусственным интеллектом, которые расшифровывают снимки с КТ, маммографии, рентгеновских аппаратов или любых других, И плюс дальше внедрение современных чат-ботов, роботизированных сервисов, которые роботы уже могут общаться с пациентом, приглашая их на те или иные мероприятия. Пока это только 29 регионов. Я думаю, что в следующем году мы подключим уже всю страну в этот сервис. Ну и говоря о конечном итоге, о развитии первичной медико-санитарной помощи, я думаю, что, коллеги, сегодня мы обсуждаем уже как бы с одной стороны вчерашний день, сегодняшний, но мы уже готовы к шагу в будущее. Что такое шаг в будущее? По сути дела, это приближение помощи к пациенту, это персональные медицинские помощники, это другой вопрос коммуникации с пациентом, это другой подход к профилактике заболеваний и сопровождение пациентов, уже имеющих хронические заболевания. Без цифрового контура это фактически невозможно. Ну и внедрение таких моделей искусственного интеллекта, как LLM, Language Large Model, то это уже фактически следующий этап развития, и мы в него уже шагнули. Поэтому, дорогие друзья, приглашаю всех в будущее.
Thank you very much, Minister. Very comprehensive response there, and I think really shedding light on the interventions that the Russian Federation have made to find themselves where they are in terms of the impressive outcomes. I just maybe just noted, for instance, obviously sustaining high levels of investment, the sort of patient-centered approach, which is also looking at the life course. I think Vanessa talked about looking at patients or users from childhood to elderly, and also a big emphasis on digital transformation, appropriate use of AI. So thank you so much, Minister. We really appreciated that response, very informative. Back to you, Octavian.
Yes, it's my pleasure now to invite to join the discussion Her Excellency Minister of Health of Uruguay, Ms. Karina Rando, to share the country's experience on something which is, we know, an important tension in the health system, which was also elaborated in the recent Lancet editorial by Richard Horton, who pointed out that the greatest policy challenges of our time is to find the right balance between enhancing the resolutive capacity of primary health care services as first point of contact and providing timely access to specialized and follow-up care. Ms. Rando, we would like to hear from your experience. How do you strike this balance? What are your actions or policy choices? Thank you.
Thank you for the question. First of all, I want you to understand that both things, the primary health care, that is more horizontal kind of assistance, because it's more holistic and is multidisciplinary, needs to be completed with specialized vertical assistance. That's the only way to achieve universal health coverage, because there are some diseases that has to be treated specialized. So it's not that you have to choose one or another. It's more try to integrate one and the other. So both are necessary. And I have two things. One would be an example of how we did it in our country. And then I'm going to talk you 2 or 3 strategies that we have to try to avoid this tension. The example of my country is, for example, we decided to have to give assistance to patients with stroke, ischemic stroke. And you all know that for ischemic stroke is a time-dependent disease, and you have to do a correct diagnosis at the first level of assistance in the primary health care, because the family doctor, the emergency doctor, or anybody that see the patients for the first time has to do the diagnosis quickly. That is, that we have to train the primary health care. That was the first step that we did in our country to implement the stroke system. And after we finish training the primary health first care, we start to do the next step. And then we advance in vertical, because we pay for all the population the mechanic thrombectomy and the RTPA medicines. So as you can see, the basis of the program are the primary health care. If the primary health care does not work well, then you're not going to refer your patients to the next level, and they're not going to receive the thrombectomy, the mechanic thrombectomy. So that is why I'm saying that we need to have both things and comprehensively teach the system, drive the system to combine both things, horizontal and vertical assistance. And then how can we do that? There's a couple of tips that we can do. One is that we have like gatekeepers. The gatekeepers are the medicals, the doctors that see for the first time the patient. The patient cannot, in Uruguay, the patient cannot go to any specialist because they like. They go first to the primary health care, and most of the specialists, except gynecology or obstetrics or pediatricians, most of the specialized doctors has to be referred from the primary health care. So in that way, there's a way of diminish the tension in the specialized and the vertical assistance, and put the tension in the primary health care, put the attention in the primary health care. So that is something that was done in our country and is continuing. And then the other thing is to try multidisciplinary teams to treat different, because vertical assistance, you assist one single disease, and patients does not have one single disease. So what can we do for that? Well, multidisciplinary teams that may treat multimorbid patients, for example, are another solution for that. So gatekeepers, referral patients, multidisciplinary diseases, and training people and specialized and primary health care to work together in different diseases and in different systems. That was mostly what we have done in our country.
Thank you very much for this very concrete example of ischemic stroke, and you brought really into the spotlight the continuum of care and the continuum between primary health care and specialized care. I also liked very much how you described the gatekeeping, which diminishes the tension while puts the attention on
Yes.
primary health care. It's something to remember. Thank you very much.
You're welcome.
Lindiwe, over to you.
Thank you. Thanks very much. We'll turn now to Deputy Minister Sharipov from Uzbekistan. What we would like to hear from you, Minister, is that we have observed, and of course the information that Uzbekistan has invested quite significantly in the health workforce and in strengthening the health workforce, and this has been a recurring theme and area of importance within our discussions. What we'd like to hear from you is, what is your advice to other countries embarking on such large-scale transformation in terms of the health workforce agenda, and what advice would you give so that they could boost the voice of health workers in the field? Thank you.
Thank you very much. Ассаламу алейкум. Разрешите выразить благодарность от имени нашего уважаемого министра Inoyatova Murashko и от имени Министерства здравоохранения Республики Узбекистан, правительству Республики Казахстан, Министерству здравоохранения Республики Казахстан, Ажар Гениатовне, Евробос, Клюге, ЮНИСЕФ и всем организаторам за приглашение и за организацию данной конференции высокого уровня. Действительно, это стремление к высоким результатам именно первичной медико-санитарной помощи в интересах людей, в интересах больного, это большого стоит. И мы рады, что мы участвуем на данной конференции. В последние годы Узбекистан добился значительных успехов в совершенствовании системы здравоохранения. У нас в республике проводится широкий спектр реформ всей сферы здравоохранения. По сравнению с 2016 годом финансирование системы здравоохранения, объем финансирования увеличился в 4 раза. Это говорит о том, что у нас сильная политическая воля главы государства, правительства и всех заинтересованных сторон. В 2020 году, 12 ноября, за один день, наш уважаемый президент принял 1 указ и 2 постановления, направленные на совершенствование и развитие системы первичной медико-санитарной помощи, организацию новой модели оказания медицинских услуг, внедрение государственного медстрахования и внедрение новых механизмов финансирования. По инициативе уважаемого нашего президента в конце 2020 года у нас впервые в республике создан фонд государственного медстрахования, и фонд является единым стратегическим закупщиком всех медицинских услуг. И во второй половине 2021 года начат пилотный проект по внедрению механизмов государственного медстрахования в Сырдарьинской области. До внедрения проекта нашими уважаемыми экспертами ВОЗ, международными экспертами, была проведена большая работа, и по рекомендации ВОЗ мы решили, что у нас государственное медстрахование будет за счет госбюджета, за счет общего налогообложения, без сооплаты с граждан. Когда мы начинали проект, мы провели инвентаризацию, хронометраж, что у нас в действительности творится в первичной медико-санитарной помощи. И результаты были не лучшими. Например, больные наши обращались к узким специалистам и в стационары на 62% без направления от семейного врача напрямую. Необоснованная госпитализация в стационарах была 40-45%. И мы начали работу с маршрутизацией наших пациентов, выработали систему направления только от семейного врача к узким специалистам и в стационары. И это дало свои результаты. У нас на сегодняшний день уже 91% наших больных идут по направлению от семейного врача к нашим узким специалистам и в стационары. У нас на 20% увеличилось посещение нашим семейным врачам. У нас на 16% уменьшилась посещаемость к узким специалистам. На 10% уменьшилась госпитализация в районные и городские медицинские объединения. На 4,7% уменьшилась госпитализация больных с инфарктом и с инсультом. Это только наши преждевременные, за 1,5-2 года наши результаты. Это дало уже свои положительные результаты. Была предварительная оценка со стороны Алматинского офиса ВОЗ, со стороны Барселонского офиса ВОЗ. Мелита Якобс, Арнольдас, Хосе к нам приезжали, и они дали свои рекомендации. Конечно же, мы обучали. У нас по указу президента создана медицинская бригада в составе семейного врача, практикующей медсестры, 2 патронажных медсестер и акушерки. То есть мы отошли от врача общей практики, от патронажной медсестры и создали медицинскую бригаду. И прикрепили к ней 2000 населения. Сейчас у нас в республике 17 500 медицинских бригад, а население у нас 36,5 миллиона населения. Мы обучили вместе с ВОЗ, вместе с ЮНИСЕФ, обучили наши медицинские бригады. У каждого семейного врача, у каждой практикующей медсестры, патронажной медсестры есть свои функциональные обязанности. и мы их обучили, и сделали индикаторы KPI по результатам работы поликлиники, по результатам работы медицинской бригады. Сейчас в данное время по внедрению новых механизмов финансирования в стационарах пролеченных случаев, в амбулаторных учреждениях подушевое финансирование. Подушевое финансирование считается справедливым финансированием. Мы разделили наши полувозрастные группы на 9 групп. Разделили. И сделали в Свердловской области по клиническо-затратным группам 59 клинических групп. И у нас сейчас после полуторагодичного, двухгодичного есть результаты тоже. У нас необоснованная госпитализация снизилась от 45% до 25%. Мы упор делаем на дневной стационар в наших амбулаторных учреждениях. Сейчас по сравнению с началом пилотного проекта в данное время у нас увеличилась госпитализация в дневные стационары на 75%. Но когда приезжали наши уважаемые эксперты, у нас есть еще проблемы. У нас не интегрирована работа семейного врача и узких специалистов. У нас сейчас уменьшилась очередь в многопрофильных центральных поликлиниках, так как уже роль семейного врача поднялась, и они уже самостоятельно решают. Поэтому немножко вначале обиделись наши узкие специалисты, что у них больных мало стало. Но нам рекомендовали эксперты ВОЗ, мы должны теперь делать интегрированное обучение наших семейных врачей, нашей медицинской бригады и узких специалистов. Мы также внедрили доврачебные кабинеты, где работают наши практикующие медсестры, и дали часть функций от семейного врача нашим практикующим медсестрам, которые самостоятельно принимают больных, которые самостоятельно решают. Из 30 больных в среднем, если за день они принимают больных, то 5-6 больных они сами самостоятельно, не отправляя к семейному врачу, решают вопросы, а где-то 25% они отправляют к семейному врачу. Но у семейного врача появилось время для больного более тщательно выслушать и посмотреть больного. Я хочу сказать, что мы на начале пути. Мы сейчас, эксперты ВОЗ нам определили дальнейшие шаги, мы этим шагом работаем. Мы здесь были год назад, видели в Алматинской области демонстрационную площадку. Мы внедряем мультидисциплинарную команду, но у нас есть еще проблемы с нашими психологами. Вот я рад, что в Казахстане на 5 тысяч населения один психолог. Мы решили пока на 10 тысяч населения один психолог. Но мы сейчас в начале пути, мы сейчас воспользуемся психологами из народного образования. И в дальнейшем у нас уже вышло постановление, мы будем обучать наших психологов. Но еще хочу сказать, что без цифровизации ни развитие, ни совершенство первичного звена невозможно. Ни внедрение медицинского страхования невозможно. А цифровизация должна идти на шаг, на 2 шага вперед. К сожалению, она отстает. Мы сделали в Сырдарье амбулаторную карту, программу реимбурсации, электронный рецепт, это все мы сделали, но пока нет еще интеграции со стационаром, с другими службами. Это предстоит нам сделать. Спасибо за внимание.
Thank you very much, Minister. That again, a very detailed and rich intervention there. And maybe just to say that I think as WHO, I think you've emphasized the partnership between Uzbekistan, WHO, and UNICEF. And certainly, as you know, WHO, I think the regional director is here, is very ready to continue the support that has been given. And thank you for emphasizing the increased domestic. I think the domestic investment is very impressive, and I think borrowing from the words of Minister Murashko, who said that you need to have your wallet. I think this is exactly what you're demonstrating, having your wallet there. And again, thanks for the remarks on basically the health insurance, and I think also identifying that we need to be pressing forward in terms of, the referral system and further integration. So thank you once again, and I'll hand over to the co-chair.
Yes, it's now my pleasure to invite our distinguished colleague, Mr. Erdembileg from Mongolia, who is the advisor to the Minister of Health. to elaborate on Mongolia's experience to use digital solutions to bridge the gap between primary health care services and remote rural populations living in sparsely populated areas of the country. What was the driving force of this policy, and what can you share in terms of your lessons learned with the other countries? The floor is yours.
Добрый вечер, дамы и господа. Прежде всего хочу поздравить всех с 45-летним юбилеем подтверждения декларации Алматы и с 5-летним юбилеем подтверждения декларации Астаны. Dear Chairman, dear distinguished guests, first of all, I would like to congratulate all of you with the 45th anniversary of Declaration, Almaty Declaration, and the 5th anniversary of Astana Declaration. It is my great honor to participate in this conference as a panelist. Well, Mongolia is a landlocked country with vast territory and severe climate. Our population is slightly over the 3 million, and we are the least densely populated country in the world, with calculation of 2 persons per 1 square kilometers. Almost half of the population lives in the capital city of Ulaanbaatar, and approximately 40% of population are nomadic herders who are living in rural and remote areas, and they are traveling around the whole year through the whole country. So the government of Mongolia is committed to implementing measures based on the leaving no one behind principle in order to intensify the process towards universal health coverage, which is a global guiding principle. Providing the population with equal access to primary healthcare services has been the priority of Mongolia's health sector policy for decades. For this reason, the establishment of primary healthcare facilities in every primary administrative unit has been sustained and strengthened. Therefore, policy continuation and consistency is one of the main driving forces to ensure equity and access to healthcare. Mongolia adopted its national policy vision until 2050 in its long-term development policy document. In this policy vision, so-called e-Mongolia program is being implemented. It supports human development and has effective results towards the digitalization of government services. Within the framework of e-Mongolia program, the health sector is aiming to create a unified health database, the introduction of remote technology in diagnosis and treatment, and set up an electronic recall system. Also, the medium-term development policy document was approved, which includes health sector goals such as expansion of the digitalization in health sector, setting up a national database, and introduction of telemedicine in everyday practices of diagnosis and treatment. In order to implement this policy, a variety of digital programs, apps, softwares were used and developed. So-called e-health software for primary healthcare services, a unified portal for health insurance performance-based financing, a program for transparency and satisfaction of primary care services, and a VHS application for mobile technology. We could witness that in an era of rapid development of digital technologies, leveraging them to improve access to healthcare services is very effective. As I mentioned before, Mongolia has a small population and large territory. From east point to west, it is around 2,400 kilometers. From north to south, around 1,200 kilometers. And 46% of total population lives in rural area, and most of them are nomadic herdsmen. It is geographically difficult to reach to those population rural areas. Therefore, the distant medicine or telemedicine, mobile medicine technology, and digitalization are the key essential elements for our country. Since 2015, with support from WHO, Mongolia has implementing has been implementing the project to introduce mobile technology in primary healthcare services, which was tailored to the country context. Mobile technology includes portable equipments, devices, and rapid diagnostic kits and trained staffs. Team visits to the remote household using the portable technologies and provide services to every household members, including elderly people, children, and pregnant women. Local citizens are very grateful for the mobile healthcare services because it is reaching out to the remote, hard-to-reach population at their homes. This initiative has been supported by the local government, Ministry of Health, and Parliament. Currently, more than 70% of all primary healthcare centers implementing mobile services.
Thank you very much. And indeed, thank you for mentioning the long-term vision, the strategy 2050 of Mongolia, which provides clear horizon of developing the digitalization, linkages between digital and outreach services, and very important, the involvement of local communities and local authorities. Thank you very much. Over to you, dear Lindiwe.
Thank you. We'll now come to Director of Maternal Child Community Health in the ministry in Rwanda, Aline Uwimana. How do you see the potential of community engagement in strengthening primary health care, better reaching the vulnerable, and enhancing health equity? We've been discussing health equity, and I think one or two of the panel members have come back to the theme of health equity. And in the case of Rwanda, this is what we would like to hear from you. And what is your advice to governments to other governments in sort of some practical ways in which they can boost community engagement in PHC towards achieving greater equity? Thank you.
Thank you. Distinguished guests, excellencies, good afternoon. So Rwanda have committed to implement universal health coverage as priority, so through different national health programs. And it has been proven that strengthened primary health care is a key component in ensuring universal health coverage is reached to deliver quality health services. And Rwanda have worked to decentralize this through different approach where community health workers come in, and let's echo the journey of community health workers in Rwanda, how it started. And as all of us here, you know, Rwanda have been experiencing the genocide since 1994. And right 1 year after, community health workers, volunteers have been selected, around 12,000, to promote health-seeking behavior and also health promotion. After all, then in 1998, where we doubled the numbers of community health workers to support in the diagnostic and treatment, especially for malaria at that time. And then in 2005, numbers were multiplied by 3, reaching 45,000, as we have roughly 15,000 villages where we counted 2 to 3 community health workers per villages, and 2 binoms were a man, a female, assigned to diagnose and treat malaria, and 1 was in charge of maternal health. During that period, policy, guideline, and treatment, and job aids were availed. They were receiving regular training in terms of providing quality services. And later in 2008, 2010, where we upgrade the package through the ICCM, Integrated Community Case Management. And from that, we added upper respiratory infection for children under 5 and also diarrhea. All these were being managed by volunteer community health workers, and at that time were introduction of the community-based performance financing to sustain and also being giving them incentive. And through this, it's not only giving the incentive, it's based on impact indicators where each and community health workers are receiving the remuneration based on the case diagnosed, screened, or treated, or referred to the facilities for upper management if need be. Then in 2016, we experienced an upsurge of malaria cases, and then as the activity they were doing were of great impact and benefits, so at that time, we were treating only children under 5. Then we look at that, and in terms of bringing the diagnostic and treatment near people, and we introduced the treatments for also adults. And since then, in terms of malaria, we have been able to reduce from the numbers we recorded in 2017 to last year, 2022, the reduction was dramatic, and we achieved the reduction at 80% for different indicators in terms of malaria, specifically in children under 5 and pregnant women, and for all the population. And this helps us to rethink and see if, based on the achievement, you are seeing that what the workforce provided by community health workers, how we can increase the number of package and bring the universal health coverage also in terms of public health to near home to the population we are serving. And since 2022, through different channels, and also it was even approved in the cabinet resolution, which is chaired by the government, the president of the Rwanda government, and this was approved, and also its financial packages. And this model is polyvalent, where from an existing package, we are adding HIV, mental health, and NCDs, the non-communicable diseases, and first aid, because we have seen with different emergency situations, so there is a need of having a first aid near home also, which can serve and also help to save life when there is any flooding or other emergency situation. So, and plus to this, we are looking how, in terms of data, we are having data on monthly basis, where community health workers reports and data are putting together, go to the health facilities through the DHS, HMIS, and these are aggregated data. So through digitalization, which is a plus to this new package we are going to make in place, we are looking also at the feasibility of having digitalization through the community health workers. So we'll have individual data of all those cases they are treating, and it will help us to track and have follow-up of what they are doing as individual data. And through this polyvalent model, so we are looking also to engage youth, where we will be, the new cadres will be also looking in terms of age. So for young to be able to access easily where they need, for example, condoms to their peers, so they are not going to seek this. For those who use older community health workers, then they can be issue of being safe when they go to seek kind of services. And also, we are looking also how to put this in kind of incentives and also retirement to those who are getting age, expand the package, and also do equal distribution of what they are doing in their villages. And of course, this is patient-centered in all the approach which will be done. To ensure equity, what you are doing is to make also the population engaged. There is what we have, the community health insurance, where all people, especially those who doesn't have a kind of monthly remuneration, and as we know, up to 70% of our population are living in rural area, and they try to contribute, but based on the wealth index category, and this is for the equity situation. And for those who are receiving the government contribution, they are being classified by their people within their villages, by their local leaders, and also their peers.
Right. Thank you.
For contributing this, we can go where to look on it helps to have this ownership where they do contribute themselves, and at high level, which leads to first accountability and access to primary health care in a timely manner, and also increase level of sustainability of what is being done.
Thank you so much. Really appreciate that. Very detailed and very impressive results. I won't go into highlighting some of the key points because we're out of time. But of course, as you know, we discussed some of these issues in great detail in our regional committee, and so we can share some of these lessons. But this is very helpful, very impressive, because community health workers is an important discussion. So over to you,
Yes.
Co-Chair.
Colleagues, we're approaching fast the end of this very rich and exciting panel. But before we conclude, and I'll invite, of course, Dr. Kluge to share his key messages at the end of this discussion. Before we conclude, I would like to invite Sıla Gürbüz, who is a representative of the Youth for Health. As we know, nothing of these plans will happen if we don't have people that are motivated to do their career in primary health care. Sıla, these ideas, these plans, have they motivated you? Or what are the elements, the ingredients that are needed to make young professionals orient their future careers to primary health care? Thank you.
Okay, thank you so much. And thank you for emphasizing the importance of young people and having me here while we are discussing future, because we are the future of our health systems. First of all, we cannot want nor be passionate about something that we don't know. As a real example, I'm a fifth-year medical student from Turkey, and I didn't know that I could choose primary healthcare as a profession until I started to learn and read about it myself this summer. It's not from my medical education. And when I realized its potential to meaningfully impact communities by providing continuous care to patients from birth to old age, and in the context of their communities and its unique ability to prevent, detect, and treat, I started to see primary healthcare as a key treasure to address all the healthcare challenges and public health issues we are discussing right now. Therefore, our health education must reflect its value and include more content and practical rotations that young people can understand and learn and experience it. And the next step, the system they will see should work effectively to attract young people. It must be responsive to the rapidly changing world, embracing new innovations like digital health technologies and fostering a multidisciplinary teamwork approach, because young people have a new vision to healthcare. And lastly, but I think more importantly, is the workers in it should have good working conditions in a safe, healthy, and supporting working environment, decent pay, ensuring that they are treated with the same respect as other specialized fields to make young people want to be in their shoes. And I want to say that, I want to finalize my words, that we deserve to have a say in our own health and well-being, and to be respected for our dignity, autonomy, and knowledge. And what I truly believe that we need our decision makers to hearing their own young generation, standing next to us and turning promises to actions together. Thank you.
Thank you very much, Sıla. I think you all inspired us. You all inspired us, and we are now very convinced that there is future in primary health care with young people motivated like yourself to work in primary health care. Hans, the job of the regional director is not easy, has many challenges. This is one of them. In a very time-constrained environment, I would like to invite you to share your thoughts. What are the takeaway messages from this very rich panel? The floor
Thank
is
you,
yours.
Octavian. I do have the advantage that we're over time, so I'm permitted to be very to the point. What I noticed is that we all have a shared commitment to the same principles, values, but of course the needs of all member states are different, even sometimes within one and the same country. So tailored solutions are important. I think we really need to continue to exchange and inspire. So this movement is very, very key. And third and last point, I would like to quote here Professor Martin McKee of the London School of Hygiene and Tropical Medicine, who was appearing in one of those virtual round tables leading up to today. What makes the difference between a declaration which is implemented or just a wish list? So number one, we need genuine political commitment, which I heard a lot. Number two, real funding, what the minister called the wallet. And three, monitoring and accountability. Who is accountable if it's going to be done or not? And of course, it's not only the leadership, it's social participation, and that's why I thought it was awesome that we finished the panel with the voice of the youth, because we promised this. I remember very well in Astana 5 years ago, when the youth was also speaking at the end. And there the youth was telling, it's not only to implement, but to be at the table when policies are being formulated. So I think that in itself shows that we did make a big progress. Thank you. Spasiba.
Thank you very much, Hans. Nothing for us without us. And with this, over to you, Lindiwe, for final concluding remarks.
Thank you very much. I think it's been a very fascinating session, a session when we're looking forward and saying, what is it that we can do differently? How can we accelerate? How can we, do a lot more in the time ahead of us? And I think what we've heard some very interesting interventions. We don't have sufficient time to go through everything, but just a few points. I think the issue of the shifts that was raised, we do need to make the shifts. We do need to be looking at health equity. The domestic investment is very important. We had a recurring theme that we do need to be, it's important to have domestic investment and invested wisely in order for us to be able to transform the health system. The issue of digitalization, if you have a country like Mongolia, of course, very important and not only, but I think right across the board, I think we are hearing about the importance of digitalization. And as we go forward into the next couple of years, this is going to be a central theme. And I think, again, thinking about Mongolia, and Aline was talking about community health workers. Yes, digitalization, but probably community health workers, but not only in very sparsely populated communities, but that is also very, very important. I think we had other themes, patient-centered and so on, prevention, all these, and these are things that we are doing, but clearly what we need to do is to implement them probably smarter and accelerate and be evidence-based as we move forward. So I'll just end my remarks here. Thank you very much.
Thank you very much, Lindiwe. It was a pleasure co-moderating with you this distinguished panel. I would like to thank our dear panelists for their excellent contributions. I would like to invite you to take your seats in the conference room. We will now proceed with the closing session. And I would like to first kindly ask our colleagues to please bring here the outcome statement. And while colleagues are bringing the outcome statement, I will